The following podcast is part of a certified educational activity titled Unleashing the Innovation Era in AML, Practice Principles and Precision Medicine with Innovative Therapeutics. Access the entire activity and complete the post-test at peerview.com/YGR860. Downloadable slides and practice aids are also available.
Hi, everybody. I think we're going to go ahead and get started. So if everybody can grab a seat, grab an iPad, and we are going to kick off our session. My name is Gail Robos. I work in New York at Weill Cornell Medicine and the New York Presbyterian Hospital, and it is my absolute pleasure to be here at ASCO with a panel of friends and colleagues. Doctors Eunice Wang, Amir Fathi, and Naval Davra we will be arguing about things related to AML. We actually have a lot to go over this evening, so we're going to divide into a few separate discussions, but actually be kind of interacting together in a panel manner for kind of enhanced discussion. And we're going to ask you also to do some participation. I'm going to toss it to the other side of the podium to Dr. Davar to kick off some introductory remarks.
Okay, well, thank you very much. My name is Naval Davar. I'm from a very different political region of the country than Dr. Robos in Houston, Texas. And so we have every spectrum covered here. It's a pleasure to discuss with all of you in a meeting that is 99% oncology, the little bit of heme malignancy that we can squeeze in. So AML, I think, is showing a lot of promise in the last few years compared to before 2010, where we really had no major improvements or approvals except for, let's say, gemtuzumab and arsenic. Now we see a number of targeted therapies, FLT3 inhibitors, IDH inhibitors, as well as BCL2 inhibitors, venetoclax, which are making huge impact, both in combination with HMA and various other combinations, and now maintenance, as well as I think in the future we may start seeing other immune treatments. So there's really a momentum being generated and progress is happening, but still, when you look at the long-term 5-year survival and cure rates, these are in the 30 to 40% range. So I think we're still at the beginning of the eventual progress that we hope will occur. Now, definitely, just looking at this, and this is modified and updated from a review that we published, and we have a new one that is coming out soon because there's so many changes happening every couple of years with new drugs. But basically, the point here is that AML is no longer one homogeneous disease, right? So if we get a community doctor or somebody calling us and say, I have a 50-year-old with AML, what do I do? There really is no answer to that question. I need to know a lot of details. I need to know if they have core binding factor, do they have a FLT3 mutation, do they have secondary therapy-related AML by either morphology or history, and then potentially in the future, do they have MLL, NPM1? And all of these will impact the frontline treatment and eventually the outcome. And even in older AML, we are starting to look at potential impact of knowing molecular mutations and adding targeted therapies. So I think we're really getting into a much more personalized, specific use of underlying molecular and cytogenetics to help fine-tune the treatment of AML. Now, despite all of this progress, and I think a lot of this may be first happening in some of the bigger academic centers, larger community, but when you look across the board in the United States using claims database, which of course have a lot of caveats and, things that one could find as pros and cons. But the point here is that there's still a lot of patients, it seems, newly diagnosed who are not getting treatment for AML, up to 40% of these patients, and in the salvage up to 30%. This number seems high to me, but I guess there could be parts of the country, where the access is limited, far away from healthcare. And so we still need to improve access. This is not clinical trials. This is just general treatment for AML. 40% are not getting it. So the goals today are really to try to improve our knowledge of AML, increase the knowledge of evidence supporting the new treatments that are approved or hopefully in the near future will be coming for both newly diagnosed relapse AML, and then to improve our skills of personalizing treatment for AML for specific molecular cytogenetic subsets, and guidance on practical care delivery, as well as tolerability, safety, and optimal delivery of various therapies and combinations, which I think is becoming a more and more important growing need. We'd like to thank the HealthTree Foundation for AML, who have been giving resources for patients to tell their stories and contribute to scientific research. They really, I think, have been one of the core groups bringing patients into the discussion in AML and future directions for AML. And they do have a patient data hub and companion research hub that you could go and look at that is trying to build a very large real-world data set of acute myeloid leukemia, hopefully in the near future. And just to show you here the way the HealthTree Care Cure Hub works, the data is being included, it's being connected to various electronic health records. And the idea is to kind of build a repository. The myeloma group have done this quite successfully in the last few years of AML patients that can then be used as kind of a contemporary control to understand prognostic markers, treatment outcomes, and comparison to emerging new therapies. So I think this is really a very, very important and meaningful endeavor. Again, just showing that the data, the plan is to have it accessible through chart reviews, data mining, and to build synthetic controls. And the idea, to my understanding, is to have it publicly available to investigators and treatment. So with that, I'm going to turn it back to Dr. Robos to get into the nitty-gritty. Thanks.
I think it's just amazing to think for a second, though, about how real-world data and patient advocacy essentially didn't exist for AML. And the reason for that was because we weren't actually having patients live long enough to either be an advocate or to really provide much in the way of real-world data. So it's extremely exciting to be able to have several hours now to present of therapies that have really changed that and have made the idea of patient advocacy and real-world information in AML a reality. Okay, so I'm at ASCO. I supposedly am boarded in oncology, which is very mysterious to me, but here lots and lots and lots of different mutations related to many different solid tumors that are much more common than AML. So for AML, though, there are a few that you need to know, and one is called NPM1. So we are going to talk about frontline management of AML patients with NPM1 mutations, and the reason that you need to know this is because this is actually fairly common in AML. This is 30-35% of AML patients, and it's one of the areas where we have a good thing to follow. So we have a marker that we can track, and we may not be needing to transplant patients. So that's why we have a whole section right now on NPM1. We also have arguably one of the coolest drugs or hottest in AML clinical trials that is also potentially targeting NPM1. So I've said it 12 times. Hopefully you can remember the letters at this point. We have a 69-year-old man with newly diagnosed AML with hypertension and hyperlipidemia who works full-time as a sales manager. Why did we do this case? We actually argued for several hours about this. So 69 is neither older nor younger. It says older at the top of the slide, but that's annoying. 69 is difficult because it's right exactly where the median age of AML is. It's neither older nor younger. And this is a person with hypertension and hyperlipidemia. Everybody has that. How bad is it? Is it really bad? Is it a little bad? What kind of coronaries does the patient have? We don't know. But he's working full time. We've got an AML diagnosis with NPM1. I just told you about that one. That's an important one. But then there are a bunch of other letters, SRSF2, DNMT3. All right, that's something. We don't know what that is, but that's something that I may or may not need to think about. And then there's a FLT3 wild type. FLT3 is also a very important one to know about, and we'll discuss why. This guy's got normal renal and hepatic function and a normal echocardiogram, and the question is, how would you treat the patient? So let's look through some of the data. So this is important. ELN 2022 is a risk stratification system for AML that combines molecular genetic data and also cytogenetic data. So those are the pieces of information that you need to come up with risk stratification. But risk stratification tells you how patients do based on what therapy they get, right? So ELN 2022, the original construction of this was based on patients getting intensive chemotherapy. And if you look at the giant red line that I actually drew, it took me a while to get that on the slide, but that line is at 5 years. 5 years is historically what is called cure in oncology. And if you look at all the different crisscrosses, you can see perhaps that the NPM1 group in the blue has a number that is over 50% of patients that are reaching that mark at 5 years, which is an awful lot better than some of the others. All the way at the top, by the way, you can see APL, which is a disease that has even much higher cure rates. But you're saying, okay, well, this isn't perfect. I'm not curing everybody, but these are patients with NPM1 who got out to 5 years. And what about the other mutations that I showed you on the previous slide that you've already forgotten? Well, if you look down at the bottom, SRSF2 pops up as a relatively new thing in the adverse karyotype adverse ELN list. So now what do you do? So I gave you one good thing and one bad thing. Well, does that even out and put you in the middle? No, not actually. And like with many things in AML, we've learned that some things look like they're more important than others. So do the other two mutations matter? Yes. But are they going to drag you out of that top category? Not actually. Your toe is going to be dripping out of it a little bit because you've got two other mutations that I've now made you worry about. That was actually my colleague's fault. I didn't have those in initially, and they wanted me to stress you out further by putting in two additional mutations. So why does any of this matter? So in green, favorable means for favorable risk AML, we try not to transplant those patients. Allotransplant's the only cure we have in AML. If you want to get to 5 years, you almost always need a transplant, except if you're in that ELN favorable group. Intermediate means maybe. You probably need a transplant, but if you're in your late 60s or 70s or 80s or 90s, that becomes hard. And if you're adverse risk, unfortunately, many of those patients, even with a transplant, aren't going to be able to be cured at 5 years, but we need to try for the adverse risk. So, okay, we have a patient who might be able to get away without a transplant. But how do we even get them in remission? Forget a transplant, right? The ELN classification doesn't tell you how to treat your patient, and you now have a patient in the office. So there are several different publications recently about NPM1 mutated AML that an oncology audience, even at ASCO, may know about, because we're talking about Lancet and we're talking about JCO. These are big published papers. And here you can see, for example, a phase 3 randomized trial looking at the addition of gemtuzumab ozogamicin to intensive chemotherapy. Most people know that intensive chemotherapy has historically meant 7+3, 7 days of cytarabine and 3 days of an anthracycline. But no, that would be too easy. Here they were using 7 days plus 3 days plus etoposide, which nobody really does, plus atra, which how did that get there? The German study looked at this and the past and showed some benefit with NPM1. And anyway, why are we looking at gemtuzumab? That's a CD33 antibody linked to calicheamycin, and a lot of NPM1 AML has a lot of CD33. So, okay, forget about the etoposide and the atra. The point here was that this trial didn't show an EFS or an OS benefit for the addition of gemtuzumab, and yet the bottom line statement of the paper, and I quoted it, the authors concluded that the addition of GO to intensive chemo should be standard of care for younger patients with NPM1. Most of the time in ASCO, we're used to it that if you have curves that are indistinguishable, that doesn't typically lead to the new standard of care. So what happened here? Here, probably it is the case, and the authors hypothesized that the older patients in the trial actually probably brought down the EFS and the OS because the therapy was too toxic for them. And actually the conclusion was, and don't forget we have a 69-year-old in this case, the conclusion was that this regimen, in particular the induction and some of the very heavy-duty consolidation, might be too heavy for older patients, but that gemtuzumab should be added along. So, okay, that's something to think about. Then this comes out in JCO. Everybody reads JCO. This is a very difficult to understand from the trial from the UK NCRI. These are complicated trials to understand, but the bottom line is that there is an even more intensive induction strategy for AML called FLAG-IDA that's even more intensive than daunorubicin and cytarabine. And here in patients who were primarily younger, but including about 10% of patients older than 60, it looked like the combination of FLAG-IDA plus gemtuzumab, so even more intensive than what I just told you about, was showing a significant benefit in particular for the NPM1 mutated patients. So not only that, these patients were getting out to 3 years at 86 and 90% MRD negative, measurable residual disease negative. So this looks like a really good regimen, except what actually is happening to the patients between 60 and 70? I'm talking about a very myelosuppressive regimen. And then MD Anderson comes out. MD Anderson hasn't given 7 and 3 in ages. That's not a thing. The head of the leukemia program at MD Anderson has hated 7 and 3 for a long time, and they have always built their intensive backbones on more intensive things like FLAG-IDA or CLIA, cladribine-based. And then they added yet another drug here, venetoclax. Venetoclax, the BCL2 inhibitor that has changed the world of AML. It changed everything for CLL. It makes everything better in AML when you add it on. And here, too, all of a sudden, you've got outrageous, it's MD Anderson, so they missed 2% of a perfect response. It's usually a 100% response rate with 100% survival and 100% MRD negativity for 100% of the patients. So how could we possibly not do this? And furthermore, there's an update of this at ASCO that's happening at this meeting. See, they did get up to 100% in the update. They missed those couple of patients, but now it's at 100%. But this is venetoclax. Well, where did this come from? I was just talking about gemtuzumab. Somebody's going to ask me in the question, should I now give FLAG plus gemtuzumab plus venetoclax? Don't ask me that, and don't do that, because we don't have data for that yet. But we do know that these are extremely active agents in patients with NPM1. However, if you look at the MD Anderson data specifically, this was a paper where they tried to compare a bunch of their intensive regimens. What you can see in the ELN favorable group in the middle, actually, is that while the addition of venetoclax has been incredibly successful for further intensification of induction, it is not 100% clear whether specifically for this group, is it going to solve the problem? Is there a problem to solve? Is it better for this particular patient who's almost 70 years old? And I think then we'll discuss this with Dr. Davar, but I think that even he might say that for a patient who's 69 years old, this might be too intense. So what about the rest of the older patients? VIALE-A changed the world of AML. This is the long-term follow-up. If you add venetoclax to azacitidine, it makes everything better, and it makes patients live longer, except there are the haves and the have-nots. So if you look at this curve, this is saying what the curve on the right shows is that only the green ones, the top ones, if you don't have a TP53, you don't have a FLT3, and you don't have a RAS mutation, those are the patients who have truly prolonged survival with azacitidine and venetoclax. Others of these patients aren't quite doing as well. This is a slightly different curve from the application of the ELN 2022 with intensive chemotherapy. The NPM1 patients are on this green curve. They're doing pretty well. And if you look here at the subgroup analysis, if you look at patients 65 to under 75, if you look at NPM1 patients, there's a strong favoring of azacitidine and venetoclax, which is a regimen that can be given very safely, actually, to patients in this age group. We know how to modify the dose and the schedule. We know how to modify it for the concomitant medications. The intensive regimens that I talked about initially, things like 7 and 3 plus gemtuzumab, FLAG-IDA, whether combined with venetoclax or not, these are highly myelosuppressive regimens that keep people in the hospital for a month with a lot of toxicity. Azacitidine and venetoclax it's not easy, but it's definitely easier than that. And for a patient who's closer to 70, who falls exactly in the group who might benefit, it's certainly something to think about. So bringing back Paul for a minute, I just want to talk to my colleagues for a second that so far, what would you guys give Paul? Intensive, super intensive, even more than 7 and 3? Do you think gemtuzumab should be added, or are you leaning away from intensive and more toward HMA-VEN? And since I've been torturing MD Anderson data, maybe I'll start with Naval.
Sure. So actually, the answer is absolutely we would not do intensive in a 69-year-old, especially if you're thinking of FLAG-IDA-VEN. All of our studies, and we say that in the papers, were actually 60. So we actually don't treat anybody above 60 with the intensive chemo-VEN regimen. So I think for a 69-year-old, I would probably be thinking more towards an HMA-VEN-based approach. I mean, we've seen the data of the 7+3 GEO that you showed by Dr. Donor. In fact, it was the older patients where they did not have the benefit. So I don't feel convinced that I would like to do intensive chemo GO there. You could do intensive chemotherapy alone. I think the debate there is if you can get the patient through, although when you look at some of the recent data like the Quantum First, in a contemporary set, the early mortality is still about 18-20% in patients above 65. But let's say you get them through, maybe you have a time-limited therapy, but you may lose 20-25% from toxicity. So to me, I think the HMA-VEN-based approach looks like the right one. Now, in the future, could you add things to that? That may be another question, but that's kind of what I would think, just putting together this patient has other co-mutations, is 69, may have a lot of toxicity, mucositis with intensive chemo.
Eunice?
I would agree. I mean, I think in general, if they were maybe 60, 59, without the spliceosome mutations, I think I would be more enthusiastic about doing an intensive regimen. And I would include, for those younger patients, as you demonstrated, the inclusion of GO based on the event-free survival data. However, this gentleman does give me a little bit of pause with those co-mutations. And the one question that you haven't really addressed, which I'm sure you will, is this 69-year-old, is this somebody that we're going to be taking to transplant? And in that setting, I think safely bridging this gentleman and making sure that we don't have mortality during the first few cycles of induction chemotherapy are going to be key. I think achieving, as you'll mention, an MRD negative state with the venetoclax-based regimen does not preclude the ability to transplant this individual. So I think that, again, these are highly, highly individualized therapies, but I think I would have a leaning towards a venetoclax-based regimen.
Anything to add? We're going to leave the transplant discussion for a minute, so just for the induction.
I won't say anything about transplant. All I'm saying is, so this is a little tricky, right? So you have a patient with an NPM1 mutation, but also, if I remember, like 2 or 3 MDS-related changes. He's the guy that still works from home or works every day?
Full-time as
full-time. Yeah, so probably a decent functional status. I'll be honest, if I saw this person at MGH, not on a clinical trial, I would give him 7 and 3. Or Vyxeos, potentially because he has AML with MDS-related changes with those alterations. I'd have to look at the sort of the VAF of all the mutations and make that determination. That's standard for that patient population at our site. As much as I'd like to give HMA-VEN, there is really no data as of yet prospectively, hope so soon, but prospectively to support using HMA-VEN in a more robust patient population that I think could probably tolerate induction. And then after you give induction, obviously you would follow that with consolidation, check an MRD, and make a determination regarding what Gail just said about transplant. But that would be my approach, standard.
So let's keep going. Let's keep going with him. I think recapping a couple of things though that are important. There are several ways to correctly slice and dice this. That's nice. We didn't used to have that before in AML. And I would say that the addition of other things to a backbone of chemotherapy is very much kind of what this entire session is going to be out. So we know that we have a little bit of discussion here for this particular patient of what will be the safest way to get him into remission. But actually, what I would argue is that once you think about the totality of his entire care, it's going to become a lot more easy to think about what you do up front. So basically, we have more help than we think, because here is a paper that just came out about a minute ago, which looks at the molecular, clinical, and therapeutic determinants of outcome in NPM1 mutated AML. Thank you very much. That's perfect for this talk. So are actually my colleagues right in worrying about these MDS-related mutations? Is that something that, should we be thinking differently? Well, sort of. So actually, what fell out here is the same as what falls out in other studies, which is if you have a DNMT3 mutation, you are probably less likely to go into a complete MRD clearance or NPM1 clearance out of the gate. And ultimately, if you don't clear your NPM1, you are less likely to be alive and well at 5 years. But the additional impact of the other spliceosome mutation is unclear. And also, they weren't actually able to find anybody in this group who was MRD negative who would benefit from an allo transplant up front. And this was an editorial that actually came along with the paper with the title, Transplant in AML, Just Follow the NPM1 Guide. They didn't write easier said than done. That was me. But actually what they're trying to say is that if you are NPM1 negative by PCR after 2 cycles of intensive chemotherapy, you don't benefit from an allotransplant. It's not promising that you're going to live forever, and it's giving all kinds of guidelines about how to monitor those patients with PCR testing in the blood. But actually, it's quite important to realize that that MRD negativity after 2 cycles of chemotherapy really makes a huge difference in terms of what happens next. And what this isn't telling you is, well, what if I got there actually with HMA and venetoclax? What if I got MRD negative with that? Is it the journey, or is it where you land at the end that makes a difference? And I would argue that if you're NPM1 negative, you're NPM1 negative. Now, what are other things that you could do? So the QUASAR trial let us know that for patients who weren't going on to transplant, that you were worrying about relapse. Guess what? Maintenance is back in AML. And QUASAR showed that with oral azacitidine, there was a survival benefit to using that drug as a maintenance therapy for patients over 55 who did not go on to a transplant, either because they couldn't or they wouldn't. And actually, if you look specifically at the QUASAR data for patients with FLT3 and also for NPM1 and also some FLT3 mutations, although not that many, the oral AZA actually prolonged overall and relapse-free survival regardless of the baseline mutational status. So here you could make a decision that, hey, I'm MRD negative. What if I hang out without a transplant? And what if I take some of this stuff? Well, there would be strong data for that. And actually, we tried really hard to help figure out how much post-remission consolidation to give. QUASAR was not designed to do that. The study was not designed to solve that problem, but basically most of the patients got a little bit of consolidation. Regardless, it was helpful to get oral AZA, and all of the trials of intensive chemotherapy so far for these patients are suggesting that 4 cycles of high-dose cytarabine, which we used to do forever, is not what we should be doing anymore. There didn't appear to be a benefit for even 3, let alone 4 cycles of high-dose cytarabine. And here for maintenance, it actually didn't matter how much you got. We also know that we have a little bit of a backdoor now, because we know that if you didn't get venetoclax up front, venetoclax-based low-intensity therapies are actually helping patients who got intensive non-venetoclax-based treatments, but then had a relapse. Let's say you're following PCR, the NPM1 goes up, you give some venetoclax-based treatment and it goes away. And some of those patients are actually trying to be stopped on their ongoing therapy. It's really early days for this, but with PCR testing for NPM1 and the possibility of coming in with an agent to mop up the problem, that is becoming a little bit more explored. I think it's very important to just end also by saying that for the patients who are getting HMA or azacitidine or decitabine and venetoclax, the molecular MRD matters for those patients too. We already know that if you follow the PCR in those patients, it's strongly prognostic. And some of these patients, for whatever reason, were brave enough to actually stop their therapy. And there are patients who are persisting, again, not for years yet, but at least for months off of therapy. So I'm hoping that that is the way of the future. I made this slide. This is my new favorite slide because I still think we should be trying to cure people with AML. And I'm not exactly sure that if you give such light post-remission therapy, I don't know if people should be on these drugs forever. Are we going to try to cure anyone? Can you give more heavy therapy up front and actually cure the disease? I'm not sure. We can argue about that. And of course, we'll talk about the menin inhibitors, which are very, very cool in the NPM1 mutated space as we get to the rest of the talks. So after all of that, now that I've shown that the spliceosome mutation probably doesn't matter that much, the DNMT3 probably matters overall, but not if you're MRD negative, I'm just curious, polling the group quickly, what would you do once he's in remission? Let's say that we started out giving him HMA-VEN and he's MRD negative in remission. Do you keep going with that forever? Do you try to stop? Eunice, you can start.
Well, I think that there is some anecdotal data, actually, that if patients are receiving Ven-Aza for 12 months or more and are MRD negative, that there are some individuals that could stop. So I think that that could be discussed. I mean, I know some of our patients, for quality of life reasons, don't want to continue to get a systemic HMA and venetoclax. I think an alternative could be to change from venetoclax azacitidine to just oral AZA. And I think there are data to support that as well. I like the idea that we can achieve MRD negativity with a less intensive regimen in a patient that could be questionable And I think that if you achieve the MRD negativity, as you just described, the patient could go on without an allogeneic stem cell transplantation. So as we talk about the interlinking between maintenance, MRD, and cure, I think this is an example of a patient that the endpoint could be relying upon all three of those criteria to get better quality of life, minimize mortality, avoid a transplant.
So, Amir, did I convince you, or not I, but did the Ottman data convince you on the additional mutations, which give one a little bit of more of an unsettled feeling that if you are MRD negative, again, MRD negative isn't a guarantee to live forever, I'll absolutely agree, but if you are MRD negative, do you still think that you would transplant this patient based on those initial mutations? Would you be willing to watch them a little bit?
Yeah, I mean, I think this particular case, again, maybe I'm just, a little bit, more sensitive than you guys, but these mutations, the SRSF2 and DNMT3A, do make me nervous. Now, the most recent categorizations of AML say these we're going to apply to potential MDS-related changes, but don't use them yet in favorable risk AML in terms of classification. So there must be a reason for that. But that they are there suggests that there is a preceding dysplasia going on, that this isn't a clear de novo AML NPM1 mutated, and it may have higher risk features. I personally, in my practice, and we have actually, folks on this dais know I'm running a randomized, despite all the stuff I'm saying up here, I'm doing a randomized study about potentially bringing HMA-Ven to these younger patients, particularly those who have NPM1 or favorable risk alterations. And in those scenarios where I feel like a patient has had a very deep response to HMA-Ven, I actually have had several of these patients come off of the study, go on and receive a cycle or two of consolidation with cytarabine with remnant MRD negativity, and approach them as I would otherwise. So they never had to go through that 30 days in the hospital with induction chemotherapy. So that's my approach. Those patients, too, I would imagine, are not going to be transplantable because they have demonstrated favorable risk. The other tricky part of this is, what does MRD mean in the setting of multiple mutations when you're potentially only looking at NPM1? If your NGS still shows the SRSF2 or your DNMT3A, but your NPM1 PCR is completely suppressed, what does that mean? So I think this case, we did this to just make it highly complicated and difficult for all of us, but just to sort of demonstrate the complexity of AML in general in terms of making day-to-day decisions.
I do think that we have to jump in, though, just to say that from a clinical practice guideline perspective, repeating next-generation sequencing at multiple time points is actually, I'm in the process currently of writing the MRD guidelines, so I can tell you that's not going to be in it, to be repeating all of these and trying to look for VAF negativity of all of these different mutations. The guideline currently for NPM1 is going to be to look at peripheral blood, not bone marrow, which the patients like, after a second cycle of intensive chemotherapy as the standard. This is going to be changing over time, but I just think Amir's point is exactly right, that we are worried about what lies beneath and what are all of these mutations doing. But I want to be careful that the implication is not to keep repeating what is intended to be diagnostic sequencing, but is not actually applicable to the post-remission setting. I'm going to give you the last word, Dhaval, and then we'll keep moving.
I think this is there's a lot of other data here that we could kind of bring up. So Curtis Lakovitz and the French actually did show at ASH that if you had these secondary mutations, the outcome was much poorer in their NPM1 subset. So again, I don't know how to reconcile those. The other thing I worry about with the Ottman paper, which I actually reviewed carefully, is that the EFS is worse. So you actually do see more people relapse, and you can salvage them better with NPM1. So I think this is a really, we talked about the HealthTree, and I kind of went through those slides, but this is actually one where you can actually talk to the patient. Say, I have these options. We could give you HMA-Ven. We could get you in remission. We could transplant you with a high cure, but there is toxicity with this. Or we could do this. If you're MRD negative, we could wait, but 40 to 45% you could relapse, and then you could bring that later. So I think it's a very tricky arena. I probably would still go with HMA-Ven, lean towards transplant today in this patient, maybe as we get more data on multiple molecular sequencing prospectively to build more confidence. But yeah, I think today I'm still more inclined towards transplant.
I think that the group has had the opportunity, hopefully, to have this polling question, the follow-up polling question. So I don't know whether, if you guys haven't answered it, go ahead and answer that. So this is our 69-year-old with newly diagnosed AML. This is the guy we've been discussing the whole time. So what are you going to do? Okay. So, I mean, I think that there's not a ton of movement, which I think is okay on this. So this actually wasn't, let's see if we go down the Ven-Aza moved a little bit more. But yeah, I mean, I think the right answer here is that there isn't an exact right answer. You would be within guidelines to do any of these different things. I do think that the sort of last word on you have different ways to get a patient like this into remission. And if you have massive toxicity out of the gate, you close doors. And I think that's something that we're all sensitive to, that if we're not really sure and we have options, it's a good moment to try to go in lighter, see how you're doing, and then come in strong with a transplant or something afterwards, rather than necessarily taking a patient in this situation and using the absolutely biggest neutron bomb that you have.
And I'm going to comment that although we keep commenting that the SRSF2 and DMNT3A mutations are poor prognosis, that's only with intensive chemotherapy. And there's data presented at the Donor 2022 ASH meeting that a new prognostic scale that this patient with NNP1, those mutations, but the absence of any RAS, P53, or FLT3 mutation would actually make this patient have a high rate of favorable response to a venetoclax azacitidine-based regimen. So I think we need to be careful about what prognostic significance we attribute to these mutations in the setting of different chemotherapy regimens.
And you can look at your slide deck that you have. That's the little graph. What Eunice is talking about is the little graph that's up in the corner of the VIALE-A long-term follow-up data. That was the graph that I included with this patient on the top curve, just if you want to look at that again. Tossing to FLT3.
Okay, so if we're not confused enough, we're going to get even more interesting. Although I actually think in FLT3, things are getting a little bit more streamlined, and a lot of the data is showing very similar directions in terms of incorporation of FLT3 inhibitors and maintenance. And also, I think FLT3s, we all agree, is very different from NPM1 in that if you don't cure these people up front, once they relapse, you don't really have multiple good shots on goal. So kind of very different disease groups with a very different approach as to how you need to deal with it in the upfront setting. So let's take this example, kind of a similar, because this is the median age of AML, 68 years of age. So that's kind of why these patients are examples we're using are kind of in that group, and has a PS of 1, has a creatinine that is slightly elevated, 1.4. Normal in most labs is between 0.9 to 1.1. Had a history of a stent 4 years ago. So has got some comorbidities, nothing screechingly bad, but there's some comorbidities. And the blaster high, which is very common with FLT3 mutated AML, and you do the bone marrow, you get a FLT3 ITD, DNMT3A, which is common, seen in about 30-35% of FLT3, and a WT1. So the question here again is, what are the frontline options for such a patient with a FLT3 ITD mutation with some comorbidities? So I think the one thing that's very well established now almost for 20 plus years is FLT3 mutations are associated with very proliferative disease. It is usually a later mutation. It's not like NPM1 or IDH that is a founder mutation or what we call a primitive stem cell mutation. But when you have this mutation, these patients present in a very unique way: high white count, high blast, visceral involvement, spontaneous tumor lysis, and is really one of the key emergencies in AML settings. So we really need to address this quickly. This is more with the ITD. Now, the TKD may not have such a fulminant presentation, and also this is the most common mutation in general across AML. Around 30% of younger and about 25% of older AML will have this. And then, of course, the big difference in FLT3 therapy, and all of these discussions have become relevant because we now had drugs called FLT3 inhibitors that are very effective at targeting the FLT3. In fact, 4 of these are commonly used. 3 of them are fully approved. So that's gilteritinib, quizartinib, midostaurin, and sorafenib is one that has been used a long time. It's never been approved, but it has been on the NCCN, and one that in the past we used. And it's kind of important to realize that these drugs, even though they're all called FLT3 inhibitors, are different in what they can target. So the type 1 drugs, such as the gilteritinib and midostaurin, can target both the ITD and the TKD, ITD is the common one, 80%, TKD about 20%. The type 2 drugs, which are quizartinib, is probably the best known in that group, have very potent activity, very good against ITD, but do not target TKD. So when one is using FLT3 inhibitor, it's important to know what the underlying mutation is so we don't accidentally give the FLT3 inhibitor that does not cover the particular mutation. So one has to be aware of that. Now with FLT3, there's very clear data across multiple randomized studies over the last 10 to 12 years, all of them showing improvement in outcome with the addition of FLT3 inhibitor, whether it's to frontline intensive chemo. Those are the two you see in the beginning, which is the Quantum First, quizartinib, or the Ratify addition of midostaurin to chemo. Maintenance setting, 2 randomized phase 2 studies of sorafenib showed survival benefit. Recently, the Morpho study with gilteritinib showed that there was clinical benefit, especially in the MRD positive, which I'll go over later. And then you have relapse refractory, both gilteritinib and in fact even quizartinib did meet the pre-specified endpoint. And of course, these are now being used both in single agents and in various combinations we will discuss. So this is kind of the current NCCN guidelines, very updated as of this year. And for patients who are considered eligible for intensive chemo, which itself is a big discussion that as you saw, we are having in a 68, 69-year-old, when do we consider them eligible or optimal for intensive chemotherapy? But if you do decide to go that path, then you have 2 options today, addition of midostaurin or addition of quizartinib. Both of them are category 1. Both of them are based on randomized phase 3 multi-center international data. And so here you have the data of the Quantum First. This was the one that was published recently about a year ago. And so there's a lot of interest in this. Quizartinib is what we call more of a second-generation FLT3 inhibitor. It's quite well tolerated, has much less GI, nausea, taste-related issues, and has been quite potent preclinically in a single agent compared to what we've seen with, for example, midostaurin and sorafenib. And in this frontline study, the addition of quiz to background intensive chemo improved survival, about a 10 to 11% absolute survival advantage at the 3-year time point. And, compared to about 20 years ago when the outcome in FLT3 mutated patients was about 20% 5-year survival, we're starting to get closer to about 50%. So definitely progress, but we still need to improve on this. I think one of the key findings from this study was, whenever we go to these meetings, and especially I think a lot of the European data sets tend to use intensive chemo and they have really, really good outcomes. But when we looked at this study, which was done in the last 7-8 years, prospective contemporary academic center study, and you look at the outcomes in below 60, no doubt these are great. We're now actually above 50, close to 60%, 4 or 5 year survival, progress being made. I think with more transplant maintenance, that could be even better in the future. But above 60, when you look at it, the early mortality is still quite significant. It was about 18% in the first 60 days in patients above 60. This is not above 70 or 75. So I think that still, even in academic centers, in prospective studies, it does seem that there is a toxicity in mortality. And I think based on this data, many of us feel for younger patients below 60, maybe 60 to 65 selectively will use it. But for older patients, I think we have to look hard at the data and see if we do feel that adding an intensive chemo quiz is the best option. Here, I think, again, the MRD data is going to be really, really important. And again, just like NPM1 for FLT3, we have a specific molecular MRD that can go down to about 10 raised to minus 6 in its lower level of detection, very similar to what we use, for example, in ALL, CLL, clonoSEQ, 10 raised to minus 6. And this is actually a modality that uses both PCR and NGS together. And actually, the first time prospectively this was looked at in a frontline study was in the Quantum First, where they added quizartinib or placebo to background intensive chemo. And you can see that there's a good difference in the number of patients who achieved MRD clearance. It was about 56% versus about 40% in the arms that got the quizartinib. So overall, we see much lower levels of VAF and much better clearance of the MRD in these patient populations. So we think that's one of the main reasons why quizartinib actually improves the survival, because we get a deeper molecular remission. Now, what about the tolerability? So in general, as I said, from the GI perspective, nausea, vomiting, diarrhea, other side effects, the quizartinib has been actually quite well tolerated. One thing we have to be aware of is actually a REMS associated with that when you start the therapy is QTC prolongation. So although this is not as high an issue as when you use this dose, which is the 40 and 60 dose, if you start giving concomitant QTC medications, we do see this could become a risk. So if you're using azoles and Zofran and Levaquin and quizartinib, then you may start having QT prolongation. So there is recommendation to use EKG monitoring in the first cycle, at least for these patients, and avoid concomitant QTC meds. The full label at this time is interesting, where it is approved with intensive induction consolidation, obviously, but it's also approved as maintenance in those people who cannot go to transplant for some reason or the other. However, it's not approved as a maintenance post-transplant Why that was made, I think it's hard to know, because the study actually did include maintenance both as part of the post-transplant as well as part of the post-induction consolidation. But I think there was just not enough confidence in the regulatory review that the post-transplant maintenance had sufficient data. So today that is not a approval on the quizartinib for post-transplant use, but it is on label to be used post-intensive induction consolidation in patients not going to transplant. Now, the obvious question is, what about gilteritinib? Is this a drug that we could use in the frontline setting? We've had it in the salvage, very well tolerated, excellent drug. So there are a couple of studies looking at this. One of them is the PRECOG study. This is a study being done in the U.S. where we're looking at randomization 7+3 gilt versus 7+3 mido. And the primary endpoint of this study is actually molecular 10⁻⁻⁶ deep PCR clearance in these patients by the end of the second cycle. So, and the study has completed enrollment. We hope to have data in the near future. And there's a larger survival endpoint study, the HOVON study, that is ongoing, which is looking at 7+3 gilt versus 7+3 mido. So I think when these data read out, it's going to be interesting to compare, because remember, the quizartinib, the control arm was only 7+3 placebo. So if 7+3 gilt beats 7+3 mido, then I think this is a higher bar, and I think there will be interest in using it. But if it doesn't, then we'll have to go back to comparing curves across studies and making decisions, and we'll have to see how to move with that. So maybe here I'm going to stop and, poll our group here and see what they would do. So to remind you, 68-year-old, FLT3 ITD, DNMT3A, WT1, creatinine 1.4, had a stent 4 years ago, and the patient is now ready, has good performance status at this point. What would be the approach? Maybe I'll start with Eunice. Any thoughts?
Oh, great. Thanks for the...
You knew that.
So for this individual, I think that I would consider a less intensive regimen. I think the Quantum First data does not support any benefit of that particular regimen over 7+3 alone, and given the comorbidities, including the age as well as the creatinine, I think this patient might fare poorly with an intensive backbone. I think that for these individuals, we also know that, and you'll show the data with the less intensive regimens, but I think I would be leaning against giving a 7+3 regimen. Cytarabine is something that could be more toxic in patients with renal dysfunction, and be worried about anthracyclines in this individual, and just their overall functionality, being in the hospital 4 to 6 weeks, etc., and really concerned that the FLT3 inhibitor and the intensive backbone are not going to serve this individual well.
Gail, any thoughts?
Yeah, I think one of the things to keep in mind here is drug availability, because I very quickly would go to the triple that you're about to talk about. First of all, triples at ASCO is just weird to me, because every single disease has at least 3 therapies.
Yeah.
But what we're talking about here is an HMA plus venetoclax plus, let's say, gilteritinib, which is, I think, where you're going to go with this, and which is something that we've actually adopted very quickly. And my immediate gut reaction is the same as Eunice's, that this isn't I'm not loving this. I've got a creatinine that's off. I got a stent. I got problems. I have the data that are not that great. And yet, I think if we were in a European audience, or even in a lot of the U.S., gilteritinib is not going to be available for this patient immediately or at all. It could really be a problem. And I think that, this is somebody who I think in a lot of settings would actually get intensive therapy, because that would be guideline driven. And I think if not, people are going to be scrounging for some of actually MD Anderson's old data of decitabine and midostaurin, for example, or even in combination with sorafenib. Some of that wasn't that bad. And if you were twitchy and couldn't get the drugs, I could imagine somebody actually doing that rather than launching into to 7 and 3. But I don't know what it would look like in Boston, but I definitely know that this is not completely obvious that all patients would be able to get gilteritinib up front with a triple.
And just to highlight, the NCC, and I think there's a typo, but aza-ven is an option for these patients, because aza-ven is across. So really you have intensive chemo quiz, intensive chemo mido, aza-ven, or aza-ven gilt. And then, of course, we haven't got to the next question, which is transplant, or aza-gilt,
or aza-gilt, yeah,
/sorafenib, right?
So the data with REALIA showed that there was no difference for FLT3 ITD mutant patients. There was no difference in the survival of patients that got ven-aza versus aza alone.
I mean, it was really the TKD that drove that.
Right.
But I think people get twitchy. If there's a nail, you want that hammer, right?
I mean, if you have a hammer, then you want to hit the nail, right?
Guilt to aza per the LACE-WING study, which had a really good overall response rate of 57% versus aza alone, and unfortunately wasn't translatable into an overall survival benefit, but my experience is that it's very well tolerated.
As before, I guess I would do something slightly different, because if I had like a 60-year-old with a creatinine of 1.4, okay-ish, coming in with FLT3 disease, who may have had a decent baseline, pre-quizartinib, I would have given 7 and 3 in MIDO. And that regimen, despite being studied in a younger patient population, is now approved across ages for induction-eligible patients with FLT3 AML.
Actually not as late, approved up until age 59, I think, based on the ratified trial.
Isn't it? I think it's approved. Is it just up to 59?
Yeah, because German studies show no benefit over age 65.
Yeah, well, Eunice corrected me.
I think it's approved agnostic.
The approval is not age-based. I mean,
it's the same with CPX. Remember, even though it was
no data, it's a support.
Correct. The data
Neither
is there.
is with CPX.
You can absolutely give this. I'm just wondering how that translates into increased sensitivity.
It doesn't. But so
Actually, if anything, they're less sensitive.
I am
doing intensive chemo. Yeah.
I guess what I'm saying, and maybe Naval can clarify this for me. When we show these survival curves and you say people over 60 did worse and people less than 60 did better, how about if we do over 50 and less than 50, or over 40 and less than 40? I mean, how much are we going to slice and dice these to get results that we think should impact patient care when the overall statistical power and design looked at the entire patient population? So I actually think that I could probably more easily get a 60, 64-year-old through 7 and 3 and quizartinib than I can getting them through 7 and 3 and midostaurin. And in fact, I'm relieved that I have quizartinib as opposed to midostaurin in that type of situation, because midostaurin is a disaster. I'm sorry for any folks that might get offended in the audience, but liver enzyme elevations, mucositis, gut issues, none of that stuff I'm seeing with quizartinib. The main challenge is marrow suppression that may ultimately in the back end increase your risk. And we cannot be sure that the worse outcome in patients over 60 is related to the toxicity of quizartinib. I think that's just the data those are just curves we're looking at. So I personally am not convinced that I shouldn't be giving this patient 7 and 3 and quiz. Having said that, I would love to be able to move to a direction where we don't have to give 7 and 3 to anybody, where we can actually incorporate second, third generation targeted agents on top of a much more gentle scaffolding like HMA-VEN. That would relieve a lot of our general consternation because, you give HMA-VEN, well, HMA-VEN sub-study analysis didn't do anything for FLT3 patients. Give HMA-GILT. Well, unfortunately, HMA-GILT, because of the design of the LACE-WING study, didn't pan out. Well, let's give quiz. Well, because, the 60 and less than 60, I mean, we just run into these situations. I think hopefully we'll get with the efforts that are coming out with quiz and gilteritinib in terms of combining with HMA-VEN a palatable, effective regimen.
But I think this is going to be, if you attend a lot of these myeloma and other meetings, that's just reality. We're going to have to get the data and we won't be able to randomize study for everything. So I think we're going to have to make this, if you look at the donor VLA subset, one could say statistically none of that is powered, right? NPM1 does better, but that's 20%, and FLT3 does intermediate, and that's 20%. So I think a lot of this is going to have to be best clinical decision making. I don't know if we'll have statistical power for it,
this is such a confusing situation. I don't want to speak for you guys, but I have had FLT3 mutated patients in this age range come in. Over the course of the last year and a half, I've given them HMA-GILT, I've given them HMA-VEN, I've given them quiz plus 7 and 3, MIDO. So I think we're presenting you cases today that don't have a simple, clear answer.
And I think what we all agree, though, is this direction we want to move, and I think the early data is supporting that, but we need more data to get universal movement. And like you said, and Gail said, there are some early adopters, there's some late. And then a lot of it's driven by trials that we have available. If we have those trials available, then of course, like a HMA Venn Guild quiz would be the best option. So I think the whole reason this is a debate, because I think if I didn't show you this part, I don't think there would be a debate. You have a label, you have an NCCN, you have a drug approved, you give intensive chemo, whether it's quiz or MIDO. But I think all of us have seen the kind of survival curves, even though that's 40%, it's a pretty big data set that doesn't look that impressive. We could do it, but are we improving, and is there an alternative? And I think with AZA-VEN, that's probably the key message here, that we have alternatives which we think in the future could be maybe as good, maybe even better, and are less toxic, and, may be able to get our patients better quality of life with similar outcomes, or maybe better outcomes. So this is kind of the one that Gail showed initially, which is the risk stratification based on the underlying molecular profiling that was done from the VLAA. So again, as we discussed, these are all subsets because obviously the study was powered for the overall endpoint. But I do think that we start seeing that there are differences in outcomes across various molecular groups. TP53 mutated does the worst. FLT3 and RAS mutated without a TP53 are intermediate. We're talking about 12-month survival. And then those who do not have any of these mutations, which is really enriched with NPM1, IDH1, IDH2, and splice mutations are the ones who tend to do better. And in fact, NPM1, there's a separate analysis showing up to 34 months survival from the VLA-8 from this paper, or a separate paper.
Highly relevant for the first case that we discussed today.
Correct. And so the splice may not have a negative impact. And even if you want to go to transplant, you may be able to do that using this path. So of course, then the question is, you have a targeted therapy, you have HMA-VEN, but the survival in FLT3 is only 12 months. It's not even better than HMA alone, which is around 10 months. So it looked similar statistically, was not that different, although it's a subset. Can you improve on that? So this is where the efforts have been ongoing. We've done them in Anderson. Now these are moving into larger multi-center studies of HMA-VEN with a FLT3 inhibitor, whether it's quiz or GILD. The data with quiz is a little bit earlier, but as you can see, the response rates, as Gail said, and that is what we saw, the response rate is very high overall, including true CR rates. The count recovery is very good in this population, but we have had to tweak the regimen. We're not giving 28, not even 21 days of VEN, because when we tried that, it was myelosuppressive. So we're actually just doing 14 days of VEN and the 14 days of the FLT3 in both of these studies now homogeneously, and that seems to give us much better count recovery between 30 to 35 days. This is the more mature data set that was published in the JCO earlier this year by Dr. Nick Short from our group, again showing very high response rates in these patients. The median age was 71, so these were predominantly older, but not necessarily VLA older, 74, 75. There were patients between 65 to 85 years of age. And as you can see, the survival is looking quite promising, although the follow-up was around 14 months. So we'll hopefully have more follow-up by this year's ASH. But when you look at AZA-VEN, we're talking about a 25% survival at 2 years. Here, this is looking closer to 60 to 65%. So I think we're seeing also molecularly, the response rates were quite deep. In fact, I find this quite interesting. If you look at the molecular that I showed you with the quantum first, 3+7 quiz, it was 56% molecular clearance. Here, we're seeing about 60, 65%. So even using a 10 raised to minus 6 assay, you're seeing similar depth. But it is a single-arm study. I think we're seeing a lot of people starting to use this. I would caution, though, especially if it's done outside of academic centers, that one has to look at the regimen. This is not AZA-VEN 28 days plus gilteritinib 120 continuous. That is highly, highly, highly toxic. So like with any combination, as Gail was saying, you're seeing at ASCO or myeloma, you have to adjust the doses to be able to deliver these drugs. So we're now doing just 14 days of both, and that's kind of what's going taken forward in the larger studies that are going to be looking at this. But I think the issue here is you don't have this available sometimes because insurance may say, well, you don't have yet approval for GILD or quiz in the frontline setting. So I guess the options then could boil down to, do you do HMA-VEN? Do you do HMA-GILD? Do you do intensive chemo? But the more important question, I think, is what do you do next for this patient? Let's say you started with HMA-VEN GILD or with intensive chemo quiz and you achieved a remission 2 months in or 3 months in. Do you transplant this patient? Do you do maintenance? And if you do maintenance, what do you do for maintenance? Do you do FLT3 inhibitor? Do you do oral azacitidine? Or do you stop therapy altogether? So, Amir, let's say you did 3+7 quiz. Okay, you, for some reason, what would you do? Transplant, maintenance, induction, consolidation, stop? Yeah.
All right. So I would do, and let's say this dude showed up, I'd give him 7 and 3 quiz. Mid-treatment, we do a marrow. The marrow is empty. We let the transplanters know. Transplanters will say, that's not enough. I want you to give a cycle of consolidation before we do the transplant. So we plan for that. God willing, he's in a remission. Hopefully he is MRD negative. We give another cycle of consolidation, again with quizartinib, and then go to transplant. The question of transplant maintenance then, as you know, resides in, we were just Gail, Eunice and I were talking about this, in terms of MRD activity prior to transplant, also prior to the start of maintenance. Both of those were combined in the morpho data and make that determination. If there is persistence of MRD positivity at either of those time points, probably most individuals would go ahead and give gilteritinib maintenance post-transplant. And I think overall these patients end up doing quite well. That's what I would do. And I guess one other thing I would say is probably, I think the opposite of that is a little bit more tricky, right? So if you or I did like an HMA-based type of approach, whether it was HMA Gilt or HMA Ven or HMA Ven Gilt, how do we make that determination as to how many cycles we would give, how much would be needed, what does MRD mean in that HMA realm? I think that gets a little bit more complicated.
Yeah. I think if you're going to transplant, it may not matter. You achieve remission and you go. But if you're not, then I think there are more questions on both. But Gail, what would you do for this patient? Let's say you started with the HMA Ven, you got the Gilt, you gave 2 cycles, 3 cycles, CR, MRD by flow, and let's say we're lucky in futuristic world and you have FLT3 and NPM1. Both are negative, 10⁻⁻⁶. Have a donor, or you have options to continue HMA Ven Gilt or do other maintenance. What would you think of?
So in general, when I look at the patients between 60 and 75, maybe 76, when I'm trying to decide whether to transplant or not, I usually try to make my life easier and sort of say, okay, if you look at the absolutely best transplant data for AML in those groups, you are looking at, and the most rose-colored data, 40-45% DFS at 2 years. And that's timed. And that's not looking into some of the super GVH details. But if you push that to 50%, that's already overboard. You're not going to find a lot of those data. So I would say that in the case that I presented, I showed you 2 different sets of curves where that patient is getting to that time point without a transplant, and I have an MRD marker, I'm hanging out. I don't see this lady getting there with current therapy. She's going to get in remission. She's going to be fine. She's got a WT1. That's where I get sensitive, but I'm not going to say sensitive. I get twitchy. WT1s don't go well. We don't have the WT1 vaccine at the moment. That was something that's been floating in and out of research. I don't think that this patient has a great way of getting to that 2-year mark with ongoing therapy of what we're doing. So I'm going to try to transplant. If she got into a smooth remission, maybe things got better with, as we treated her with the triple. I think it's a really hard conversation because patients absolutely do assume that they're going to be cured with transplant, et cetera. But I think this lady would be in some serious trouble. Now, that said, if you can't do it, you can't do it. And then for sure, she's going to go on to maintenance, and we're going to follow, and we're going to throw things at her if there's a molecular relapse. And there are actually data for that too, that for molecular relapse on FLT3 to do things. But I think she needs a transplant.
Yeah. Eunice, are you using molecular, or let's say if you had access to it, FLT3 NPM1, and you got this data, would you use this today for a transplant determination, or is it the baseline, as Gail said, which I kind of think that too, is it the baseline co-mutations that drive that early decision? So is it baseline fate that this person is high risk, I go to transplant, or is it dynamic? Well, I got NPM1 and FLT3 10⁻⁶ negative. Maybe I don't need transplant.
There's no NPM1 here, though. You've got a DNMT3.
So this one would be just FLT3, right? Okay. Just FLT3, yes, okay. Correct. Clearance.
So to answer the question of MRD, we are using every modality known to us to look for MRD. So we are at an NPM1 mutant, FLT3 mutant patient, NPM1 mutant. And so I checked MRD by flow, by NPM1 and qPCR, and by the FLT3 ITD MRD assay, as well as by morphology. So I use every modality to look for MRD in my patients, because every single study that I've looked for in AML and practically every other disease says the presence of MRD portends a worse outcome. In this particular patient, I think we're a little bit challenged. And I think, again, this is where the role of shared decision-making really plays an important part. I think it's certainly if this patient is somebody that having that discussion up front that they have high-risk disease, making that decision, do you want to go for a potentially curative transplant? I think that I would favor a less intensive approach if I'm not able to put them on a triplet study of a FLT3 inhibitor, ven, and an HMA, that I potentially would do ven HMA, knowing that with the FLT3, they would likely recur with the FLT3 and then do sequential, maybe GILT AZA. If I had the option of a triplet therapy and they wanted to go to transplant, I would do the triplet therapy because I feel that a triplet therapy is much more likely to make this person MRD negative, and then they could go for a transplant. But if they don't want a transplant, then I would potentially do sequential doublets to try to give them the longest disease-free survival, disease control. I do think that a reduced intensity regimen would be reasonable in this individual if they've achieved an MRD negative response, which is probably what my transplant team is going to want now that I'm going to look for them. And I think that person could survive a transplant with post-transplant Cy, and that I would potentially, if they were MRD, FLT3 IgD positive before transplant, I would follow that with post-transplant GILT, and if they were MRD negative, peri-transplant, I would do observation after potentially curative transplant.
So a lot of different options there. So let's see what the audience thinks. So 68-year-old with new AML, PS1, creatinine 1.4, stent 4 years ago, you heard the NGS baseline. What would be the upfront treatment strategy here? 7+3 transplant, adding FLT3 to intensive chemo, then transplant, triplet, then transplant, HMA ven alone, I'm not sure. Okay, so again, kind of a split vote, slightly more towards HMA ven, FLT3, but still intensive chemo, which I think is definitely still in label and an option, and then some with HMA ven. So let me go here quickly through some of the maintenance data. So let's say with this patient achieved remission, MRD was positive, pre-transplant. Let's say that the patient declined transplant, and what are the options here? Or if you went to transplant, what are the options here? So we do have now options for patients who don't go to transplant, FLT3 mutated. You have actually two options. One is you could continue the FLT3 inhibitor quiz if that was used in the frontline induction consolidation. The second is you could use oral azacitidine CC486 because that is a mutation agnostic label for maintenance. And then for those who do go to transplant, even though there's no quote-unquote full label approval, but the NCCN does acknowledge that there is data with a number of them, including sorafenib and gilteritinib and quizartinib. And so these are options as well that could be used in patients post-transplant. So post-transplant, there was a very large study. It was kind of the first randomized large maintenance study with a targeted therapy post-transplant called the Morpho study that looked at the use of gilteritinib versus placebo post-transplant in patients with a FLT3 ITD mutation who had undergone transplant. The primary endpoint of the study was event-free survival, and a key secondary endpoint was OS. Maintenance was usually started between 30 to 90 days, and they had some criteria that had to be met. Now, the primary objective of RFS was just missed. In fact, the p-value was 0.051, but you do see that there appears to be some clinical benefit. For OS, there was not as much benefit, although the primary endpoint was the RFS. This study did use a very specific molecular MRD using PCR NGS going out to 10 raised to minus 6 sensitivity. And to me, I think that's the most important or interesting data that has come out of this study. So about half of the patients in this study, 50%, had MRD positive either pre or post-transplant using that 10 raised to minus 6 FLT3 PCR NGS assay. And those patients, you can clearly see the use of maintenance benefited. But I don't even know if you really call this maintenance. This is basically molecular MRD-directed intervention or therapy that will improve the outcome. For the others who did not have any detectable molecular residual disease at a high sensitivity 10 raised to minus 6 assay, there was no benefit. So I think the way a lot of us are thinking about it is we will use this molecular assay. We will get the 10 raised to minus 6 sensitivity assay pre and post-transplant, and in those who are anything detectable, we will consider the use of maintenance. This slide I thought was very interesting because this was shown by Mark Levis at the ASH meeting, where they actually show that every level of MRD has therapeutic impact. You see this in ALL. We've never seen this in AML, where every log of MRD as you go down improves your survival. So MRD4, MRD5, MRD6, no MRD, and you look at that nice separation of the curves. And it was true on both the GILT and placebo, but the GILT in each case did a little bit better than the placebo at any level of MRD. Overall, the regimen was reasonably well tolerated. There were cytopenias, including neutropenia, that one has to be aware of. So I think the key endpoints here are MRD positive patients from this large 400 patient study did show benefit of gilteritinib in those who had any detectable molecular FLT3 MRD pre or post transplant. And then patients who are MRD negative in general, we may not consider maintenance. And in those who do not have transplant, at this time, there's no clear randomized data that shows survival benefit. However, subsets of the study, including the Quantum First and Ratify, both included maintenance and have used it. And then just to highlight here, let's say the patient did not go to transplant. So for this patient, you have two options. One is using quizartinib, continued as a maintenance therapy. And here you see those patients who went to transplant have the better outcome. But we know that there are a lot of patients who may not make it to transplant, either because of comorbidities, age, finances, logistics. And even in that case, those patients did benefit from the addition of quizartinib. And this is one of the reasons the FDA did give this approval in the patients who did not make it to transplant, and I would consider the use of quizartinib. However, here you also have data with CC486, oral azacitidine, that could be used as a maintenance in patients who are not going to transplant. And in fact, both in FLT3 and NPM1, there was a subset analysis that showed a survival advantage. So I think it's a good question. We're a little short on time, so I'm going to leave this for now. But if we get more time, we can come back and talk about maintenance in those who do not go to transplant and what the options are. So I'm going to turn it here to Dr. Wang to discuss IDH, please.
Thank you so much. I'm going to be talking about a patient. So now moving on to the next case. This is Owen. I don't know who picked the name. So this is Owen, a 74-year-old gentleman who was recently diagnosed with AML, who presents with an ECOG performance status of 2. So he has multiple comorbidities, including hypertension and likely, possibly, all the associated cardiac risk factors. He presents with progressive baseline thrombocytopenia, neutropenia. Evaluation of his AML demonstrates intermediate risk cytogenetics as well as an IDH mutation, and he is wild type for FLT3 ITD, 30% blast. So can we characterize this presentation and what are the next steps? And so as part of the diagnostic workup of any new patient with newly diagnosed AML, we are going to perform a comprehensive workup, which includes not only assessment of the patient's performance status. I would caution against using age as the only way to determine whether somebody should get certain therapies. And we now have newer tools, as mentioned by one of the audience members, including frailty indices and gait speed, et cetera, to assess performance status. But for the biology of the disease, we have identified IDH mutations. So IDH mutations are not the most common mutations we see in newly diagnosed AML. In fact, they're fairly uncommon, with IDH1 only making up as little as 5% and IDH2 about 10%. So in general, when we look at IDH1 and IDH2, we find them in up to 20%. So that means maybe 2 out of 10 patients newly diagnosed. And there was a lot of debate about whether these IDH1 and IDH2 mutations can be considered prognostic. And you can see that there is a lot of controversial data, whether they're better prognosis, worse prognosis, and neutral. And so the assessment of whether these are good or bad, or even potentially associated with clinical hematopoiesis, does involve a little bit more complicated assessment of these patients. And so the question is for this 74-year-old gentleman who has markedly more comorbidities and poorer functional status than the 2 patients we've discussed previously, is what would be the best frontline option for this patient with IDH1 mutated AML. And so obviously we are trying not to advocate, for example, FLAG, IDA, VEN, or FLAG, GO, unless you are at MD Anderson. And we are really going to be looking at what we call a less intensive approach for these individuals who live outside of Houston. So we're going to say, what would you use? What are the options? And so, as you can see here, again, referring back to the NCCN guidelines for patients older than or equal to 18 years of age who are not candidates for intensive chemotherapy. And you can see that the options category 1 is either azacitidine, venetoclax, or ivosidenib azacitidine. And this is actually a deviation from previous NCCN guidelines, where the workup was really divided into all of the different mutation types. And because of the strength of the data that we have, for example, with Ivo-Aza and Ven-Aza, both of these options are listed as category 1, because they're both supported by randomized controlled data. You can see other recommended regimens include decitabine venetoclax and ivosidenib, which can be recommended, again, based on that initial assessment of the patient's frailty. So, for example, if the patient is in a nursing home, they're not mobile, their performance status may be more than 3 or 4, they're not able to travel to the center to get azacitidine, which in our center requires 7 days a month, coming daily to my clinic. They may be better candidates for something like single-agent ivosidenib, which is associated with the CR rate about 20% and about overall clinical benefit in 40% of individuals. Alternatively, one could look at a different regimen, decitabine and venetoclax, which again was explored in the phase 1b setting, but not in a randomized phase 3. You can say LDAC venetoclax or decitabine monotherapy, certainly again in those poor performance status patients, could be considered. And then similarly, azacitidine and anacetinib have very similar data as our data with IDH1 inhibitors. However, those again have not been assessed with the same level of randomized control data that we see with the other agents. So practical considerations of the ivosidenib as well as anacetinib include the common hematologic toxicities and the interactions between these drugs and azoles and the importance of monitoring, for example, QTc interval, and again, with the hematologic toxicities, bleeding events. Differentiation syndrome, however, is the black box warning that has been highlighted by subsequent reanalysis of the original data by the FDA. And just to highlight that this differentiation syndrome can lead to fatal events and can be, with both the IDH1 and the IDH2 inhibitors, somewhat delayed. So unlike what we see with APL, this is not something that would occur, for example, within the first week or two, but can occur all the way up to, I think the FDA in the label says up to 100 days when patients are outpatients. So something to keep in mind. Management of differentiation syndrome is similarly across all of the syndromes, which is cytoreduction, in this case, Hydrea, as well as corticosteroids, specifically dexamethasone 10 milligrams BID. So moving on to the data. So AGILE was one of the most successful studies that have been done in correlation with the BLAA trial in demonstrating the superiority of one regimen over monotherapy alone. In this trial, patients were randomized who had IDH1 mutations diagnosed at the time of AML presentation to receive therapy either with placebo AZA or ivosidenib azacitidine. You can see clearly here the difference between those two curves. There's no, if you can see that actually is a remarkable difference, and a remarkable difference in the prolongation of event-free survival. And this obviously led to the FDA approving ivosidenib in combination with azacitidine for these older adults. I wanted to highlight here again, in combination, you would think potentially with azacitidine that the potentially theoretically, quote-unquote, cytotoxic effects of AZA would obviate differentiation syndrome, and that was not true. We did continue to see about 14% of patients treated with the IVO-AZA developing differentiation syndrome. However, you can see here as highlighted that in contrast to venetoclax azacitidine, we do not see any more hematologic adverse events with the combination of IVO-AZA as compared to placebo AZA. So we are not seeing the need for that daily transfusions, and we saw much fewer infections related to therapy. And after a median follow-up of 28.6 months, you can see that these results show an even improvement in the efficacy of IVO-AZA, which is in contrast to the follow-up data with VLEA, which showed no change in the median overall survival of patients after a 4-year follow-up. And again, improved remission rates are markedly different. There was a question from the audience saying, when would you expect to see response with the combination of IVO-AZA? And the response occurs very, very quickly, within a couple months. And so the bone marrow biopsy could be done at that time point. But again, hematologic improvement might be an early sign that this combination is working. You can see here, this is the data with venetoclax in IDH-mutated AML, and as mentioned by my colleague here, it works very well in IDH2 mutant disease over here on the right-hand side. again, with prolonged overall survival in both of these groups. And one would say that the data with IDH1 is actually better than the data that we see with IDH2 is better than the data that we see with IDH1, with the overall survival that's not reached in the IDH2 patients as opposed to the IDH1 patients. And you can see here the hazard ratios and the favoring of both of these IDH mutant subsets with the administration of Ben-Aza. So the question is, what would you give? Would you give Ben or would you give Aza? What about would you give ivosidenib, Aza? And what about giving all three? So here's another example of triplet therapy. And this trial here showed in the newly diagnosed patient population, again, a 92% high composite CR rate, again, done at MD Anderson. But regardless, you can see that a high composite CR rate in newly diagnosed patients, and again, a median overall survival with the triplet therapy that was not reached. So what if this patient had presented with IDH2 mutant disease? Would you have faced a similar choice? So before we go on to this, I'd like to ask my colleagues, given both the category 1 recommendations for Ivo-Aza as well as Ven-Aza, so just turn to Gail, which one would you choose for this particular patient?
So, I mean, I think it's great news that they both work. We definitely have, for known IDH1 mutated patients, we've gone with the ivosidenib and azacitidine. I think that probably the best way to put it is it's easier. There is less myelosuppression, and we feel it works as well. That said, there are frequently patients who have delays in diagnosis or we don't know right away. I don't tend to recommend sitting and hanging around and waiting. You can sometimes, but I think that there are different barriers for different patients sometimes in getting ivosidenib, and doctors are very familiar with venetoclax, and if it's going to be a big kerfuffle to get it and it's going to be a delay and they're not sure and so forth, I think that both regimens work. But in my practice, they would get Ivo.
Okay. So Naval, are you doing triplet upfront therapies in these patients? What are you doing at your center?
Yeah, I mean, just to caveat, all of this data from Anderson is clinical trial. So yes, in clinical trial, we would do triplet, which is what majority of our patients go on. So yeah, if we had an IDH2, we would do Aza-Ven. ENA, if it was IDH1, we'd do Aza-Ven, Ivo. Now, if they're not going on a trial, it depends on where they're getting treated. If they're going to stay with us, we're comfortable with the triplet. We've got experience safety. We would do that. If they're going back, especially if it's in a community setting where the doctor is not familiar, we may actually start with Aza-Ven or Aza-Ivo and then use the other drug. I think IDH is very different from FLT3 or KMT2A. I think here you already have a 30-month survival with Aza-Ivo. And in salvage, some of them will respond to Aza-Ven. So you're already at a very high survival. So to beat that, I think you need to show like 40 plus months. So sequence may actually, I think, be very relevant here. I think FLT3, KMT2A, you're at a very low early survival. So I think upfront we'd go more aggressive.
Can you clarify, though, when you're doing that upfront triple, are you doing the triple forever?
No. Yeah, so actually one of the Aza-Ven guild studies called the Viceroy study, which is now Astellas sponsored multi-center, we're going to do a planned de-escalation. So for 4 to 6 months, you get the triple therapy. Then we drop to a doublet Aza guild for the next 6, and then single agent guild after year 1, which there's debate on whether we could stop that at year 2 or not, depending on consecutive longitudinal molecular clearance. But for most of these, that's kind of, I think, the direction we're going. You know, some in our group still feel that the synergy of the 3 drugs, so even if you have to reduce them, give less Aza-Ven and Ivo, we'd prefer that. I personally think that we should start stopping after 4 to 6 months and see if we can actually cure people and stop therapy at some point.
I just think it's important to mention for the audience, though, that you guys are constantly innovating with respect to the dose and the schedule and the number of days and so forth. And I think that it's worth it to note that from meeting to meeting, this actually changes. So to put somebody, quote unquote, on 3 agents for an IDH inhibitor, I think you're going to be swimming around in remission, not sure what to do next without a trial to guide you.
And I think IDH, again, I think it's, I was just talking to somebody earlier before this, I think I don't know if there's going to be a need and if a triplet will show the improvement because you're at a very high level. So I think we have to think of each molecular group as where I would take a risk. You need something, the outcome is not good. Versus here, I mean, I may do okay with a 75-year-old, get a couple of years, then do the other one, get a couple of years. Yeah, so.
Okay. Amir, would you do anything differently or any thoughts?
I don't think I have any thoughts that are groundbreaking. For IDH2, I would do HMA Ven, and for IDH1, I would do Ivo Aza. The only thing I think was brought up earlier is not everywhere do we have rapid testing. And when you have an AML patient who comes in, IDH1 mutations are uncommon. I think it's a shame that we don't have as rapid a testing as we should more broadly have, to sort of identify these patients that may potentially benefit from a more gentle treatment that will allow their blood counts to come up sooner. So that's the only thing I would just add.
Okay, so I think, what about if this patient had IDH2? So you can see here, again, not as strong data, but there certainly is data supporting the superiority of enasidenib azacitidine versus azacitidine alone for IDH2 mutant newly diagnosed AML. Unfortunately, then this was, again, not a placebo-controlled trial. So because of subsequent therapy, there was no difference in overall survival, but certainly a remarkable difference in event-free survival. So this certainly is a regimen that could be utilized. And you can see the CR/CRh rates are very similar to venetoclax azacitidine. However, on this trial, it was just the appearance that maybe the median overall survival was less good than with the ven-aza combination, which is what Dr. Fati was addressing. And what about the triplet of enasidenib, azacitidine, and venetoclax? This has been studied only in a very small number of patients, and again, appears to be effective. But again, is this going to be an improvement upon aza-ven alone? It's not certain. So what about sequencing? So this gentleman went ahead and received venetoclax-based therapy per the REALI-A, received a rapid remission. However, after 3 years, which is a reasonable time to have a duration of response, he relapses, and repeat molecular testing at that point demonstrated the persistence of the IDH1 mutation. So what are we doing for relapse refractory disease? And this is the current NCCN recommendations based on the molecular features at the time of relapse. Now, we're not necessarily recommending full next-gen sequencing panel, but definitely the assessment at the time of relapse should include those molecular aberrations for which we have active targeted therapies. And you can see here some of the targeted therapies that we will discuss, although it is missing menin inhibitors, which Dr. Fati will be discussing in his next presentation. So we now have, at the time of relapse, a second IDH1 inhibitor, lutocitinib, which is really a second generation brain-penetrant and highly selective IDH1 mutant inhibitor. It does lead to grade 3 or 4 treatment-related adverse events, including about a 20% incidence of febrile neutropenia and 16% incidence of thrombocytopenia and neutropenia, as well as persistent differentiation syndrome. However, in patients with relapsed refractory IDH1 mutant disease, we are seeing a very durable duration of response. The overall CR/CRh rates are still in the 35% range, which is similar to what we see with ivosidenib, but you can see here the durability and the overall response rate lasted for over 20 months for whatever reason. And median overall survival was 11.6 months, but in those, again, who had achieved a CR/CRh, we have an 18-month survival of 68%. Now, those data were generated in the pre-venetoclax era. In this particular patient, as we just demonstrated, this patient received venetoclax in the upfront setting. So what is the activity of olutasidenib in patients received prior venetoclax? And there's some very early data demonstrating that out of the 16 patients who had received prior venetoclax, about 25% of them achieved a CR, and another 7 achieved a CR/CRh. So high activity levels despite the prior venetoclax exposure, which is particularly promising. What about the evidence with Ivo and enasidenib in the same patient population? Not quite as good. You can see the overall response of 53 patients who received FLT3 or targeted therapy after disease progression on venetoclax was poor. So in some of our other established agents, the exposure to the BCL2 inhibitor, I believe, may result in a pan-chemo resistance that then makes them insensitive to the administration of targeted therapy in a large percentage of patients. And so, as you can see here, there's some retrospective studies, again, looking at patients treated post-venetoclax therapy, and again, very, very low response rates in retrospective studies.
So I've been tasked today to talk about emerging fancy targeted therapies in AML and specific focus on menin inhibitors, an area with which myself and Eunice have been very, very knee-deep involved over the course of the last couple of years. So I'm sure we will have some interesting comments, maybe not. So begin with a case, 69-year-old female named Dana with relapsed refractory AML, progressed on 7 and 3, unfortunately, got a subsequent venetoclax platform, which I assume is HMA-VEN. The initial diagnosis was 9/11 translocation. That was subsequently confirmed when the patient relapsed with the same KMT2A, otherwise known as MLL rearranged abnormality. And the questions are this: what is the patient's current prognosis? And if we're not talking about KMT2A rearrangement, but the other target of menin inhibition, NPM1, how would relapse with an NPM1 mutation following initial response have an effect on prognostication? So let's start with the KMT2A business. So Gail, when she was doing her initial slides, showed these nice survival curves of all the subsets, the molecular subsets, and then she had superimposed that big red arrow to show us, was it 5-year? The curve that was like the absolute worst there included KMT2A. KMT2A is rough disease. These patients are inherently resistant to traditional cytotoxic therapy. They oftentimes have therapy-related AML from prior exposure to anthracycline agents. They oftentimes present with really high white blood cell counts, marked extramedullary disease, meaning the disease just infiltrates all sorts of tissues and organs and gums and skin and gut and spleen, and just a complete mess, oftentimes with a high white blood cell count. So the likelihoods of something bad, like a bleeding episode, a DIC episode, some shock-like transfer to the ICU and hope for the best type episode happening is quite high with these patients. And unfortunately, many of them are quite young. And I sort of dramatized that, but here you go in this boring bar graph. KMT2A rearranged AML is demonstrably associated with a higher early mortality rate and increased risk of bleeding and coagulopathy. And this is 60-day mortality. I think Naval told me that this came out of his group at MD Anderson, where the likelihood of dying is much higher in these younger patients, oftentimes who come in with this disease. And the bleeding and extramedullary manifestations are particularly difficult. And this becomes relevant when we talk about menin inhibition and its potential adverse event profile as well. There is, I would say, a lack of effective therapy for KMT2A rearranged, also known as MLL. So when I say KMT2A, I'm talking about the same thing. And it's a true unmet medical need. It's not very common among adults. I would say 2 to 5% of all adult AMLs have maybe KMT2A rearrangements. It's much more common in children, particularly infant pediatric leukemias, but also pediatric ALL can be seen and is considered a higher risk feature. And as you can see, this is all shown here in terms of this overlapping features of KMT2A, also seen in a good number of patients with mixed phenotype acute leukemias. The incidence globally, not in the United States, globally is around 7,000 per year, which is not high at all. But unfortunately, regardless of the fact that these patients are oftentimes young, we're looking at 5-year overall survival rate of less than 25%. That's similar to what you would get probably with MDS AML in an older patient. So it's really, really a tough crowd. All right, so that's one target of menin inhibition. How about NPM1? Nucleophosmin, NPM1, has long been recognized as a distinct disease type. Majority of these patients present with de novo myelomonocytic AML, can have leukocytosis, sometimes extramedullary manifestations, not as frequently as KMT2A. They can co-occur with other mutations, as we've talked about ad nauseum today, FLT3, other potentially MDS-related changes, and in which case it may impact how well these patients do. So if you have a DNMT3A mutation or a FLT3 mutation or a certain MDS-defining alterations, probably the likelihood of good outcome that is generally associated with an isolated NPM1 mutation all by itself is muted. So that's something to recognize. So when we say NPM1 is a great thing and, we'll get you in a remission and clear your MRD and you don't need transplant and go with God, everything is great. Well, not necessarily. Over the course of the last 15 years, I've lost many patients with NPM1 mutations, particularly when they relapse, in which case the outcomes are not nearly as good as can be shown here in this table. And patients who have had relapse in general have worse and worse and worse outcomes with every subsequent relapse. And particularly those patients who've been exposed to venetoclax and then relapse, they don't do particularly well either. Presenting with relapsed AML, got 7 and 3, got venetoclax, has KMT2A. So when should we be testing? So let me open up the forum here, and I'll reach to my right here with Dr. Wang and just get an idea regarding, because this is a topic that comes up quite a bit regarding how to assess KMT2A rearrangements. How do you do it at your cancer center, and how quickly does it get to you?
So we do it. We have conventional cytogenetics available Monday through Thursday, and on Friday, and or if there's a high suspicion of a specific rearrangement, we do overnight FISH. So for this individual who's known to have a KMT2A rearrangement at the time of relapse, we would probably be doing an overnight FISH to determine that abnormality. And particularly because of the availability of potential targeted therapies, identification that aberration is still present at relapse, I think would be very important in terms of selecting the next options for this patient.
So that would take, 2-3 days, you think, to?
Probably 2 days.
Yeah. How about you, Gail?
So these don't usually go away at the time of...
They don't.
So once they're there, they're there. So I would say that I think the most important thing is that you're going to decide whether you have a FISH panel that's going to include it, or if your center is doing an RNA fusion panel. We actually are doing both. So we're having this expanded RNA fusion panel, which I think is kind of going to wipe away everything soon. I think for most of us, the molecular testing is just going to wipe away a lot of the other stuff. But basically, your FISH, you should pick it up. We can get that back actually usually in 48 hours. And then for relapse, it's. I mean, if you're on a trial, you might have to, but they don't go away.
They don't go. No.
So the most important thing that I've actually found is that it's there, but people are not looking for it because you're getting lost in the letters. It's MLL, KMT, and it gets lost in the commas and the letters sometimes. So I think that's an important kind of educational moment to go backwards and make sure, was it there? Did it get looked for initially, and did it somehow get missed?
In my experience, and the reason I bring it up, not necessarily because this patient's relapsed or newly diagnosed, KMT2A rearrangements come up a little bit later than all the other point alterations that we get. Not now. We have this rapid sort of 2-3 day thing where everything comes in, fusions, mutations, so KMT2A is included in that. But previously, I remember we would get the 3 NPM1 IDH alterations, and then percolating in about 3-4 days later would be, well, maybe we have this, we have to FISH for it. And that's relevant. And that's kind of tricky here, because if you're going to pick an AML crowd that is timely in terms of the need for treatments, it's these guys. They can really fall apart quickly for the reasons I mentioned. So that's, I think, a good reason to sort of bring this up. And then I just wanted to jump, because we don't have that much time, sort of the clinical experience to date with menin inhibitors. Now, I assume there's a good number of folks in the crowd who are interested in these agents. Menin inhibitors are small molecule inhibitors of the interaction between menin and KMT2A. And these enzymes are essential for the myeloid maturation of early precursors in the marrow. And that interaction between menin and the altered KMT2A leads to an enhancement of MEIS1 and other oncogenic factors that then promote leukemogenesis and stunting the appropriate maturation of myeloid cells. So there's this interaction between menin, KMT2A, upregulation of certain leukemogenic factors, and then the phenotype in both NPM1 mutated and KMT2A rearranged AML. And the first drug out of the gate was revumenib, and it was studied in both phase 1 and phase 2, and recent data has actually been published and presented looking at this agent in both pediatric and adult patient populations. Ziftomenib, that Dr. Wang and myself have been quite involved with, has also similarly been studied in phase 1 and phase 2, and is showing a good amount of excitement. But that's not it. There, the Johnson & Johnson folks have one, Daiichi Sankyo has one, Biomea has one, you name it. So there is a whole host of different menin inhibitors now in various stages of clinical development. Let me start with the COMET study, which is ziftomenib's the phase 1-2 study. The phase 1A was just a dose escalation, dose finding segment of the overall clinical trial. And as per the Project Optimus, the goal of phase 1B was to then establish 2 particular dose levels where we're going to go back in and do a deeper dive in safety, tolerability, pharmacokinetics, get a better sense of what these potential doses are using specific PD markers. And then we ultimately settled on 600 as the most pharmacokinetically and pharmacodynamically and clinically optimized dose, leading a particular expansion with a focus on NPM1 mutated patients, and most recently have conducted a larger study of NPM1 mutated patients in a phase 2 study, which we hope will ultimately lead to the greater availability of this agent for NPM1 mutated patients. And the primary endpoint of that study was remission rate. This is some of the data on how these patients were. Generally, the age range is similar. There was a female preponderance, which is interesting. What I'd like to just put your attention to is the median number of prior therapies, range of 1 to 10, 3 being the median. A decent number of these patients had prior venetoclax exposure. 20% had a prior transplant. A good decent number had FLT3 and IDH2 mutations. So a good mishmash of what you would expect in a relapsed refractory AML patient population. This is some of the toxicity data from the NPM1 mutated patients that we presented at EHA last year. There was a range of treatment emergent adverse events that were seen in 20% or more patients, but the ones that were thought to be related only were nausea and differentiation syndrome. Now, differentiation syndrome, as was noted earlier with IDH inhibitors, can be definitely seen with menin inhibitors, and particularly in patients, in my view at least, with KMT2A alterations who have a lot of extramedullary aggressive disease. And so certainly monitoring for carefully DS and this patient population is essential. We didn't see QTc prolongation with ziftomenib. It had been reported, obviously, with revumenib, although it seems to be managed quite effectively in those clinical trials. Here is the clinical activity of ziftomenib. You have basically a 35% CR rate and a 40% composite remission rate, and then one additional patient who barely did not meet the criteria but was an MLFS. So overall, we're starting to approach around 50% of patients having very good marrow response among these NPM1 mutated patients, many of whom multiply relapsed and refractory. If they had a concurrent IDH mutation or a FLT3 mutation, it did not seem to matter in terms of the proportion responding. And then one interesting finding is that by the time you get into cycle 2, 3, 4, you see this rise in both platelets and neutrophils, and that's generally what we have seen. Responses are that early are not too common before the end of cycle 2, but then thereafter, if we're going to see activity, we see it. So the median time to response is around 50 days. It's a swim plot for you guys to just get a general sense. The gal all the way at the top, that I believe is my patient, who I'm telling you, she's a young mother of 3 children, 6 prior relapses, NPM1 mutated, got this and went into a long-lasting remission, years, and unfortunately died of an unrelated coronary event. But a lot of patients have done really quite well, and some patients post-transplant have received Zifto as maintenance therapy. Revumenib, similarly impressive results. You have a median overall duration of response of around 9 months. Overall response, all marrow responses of 50%, CR of 20%. Composite remission rate is around 30%. It's important to note that there were a substantial larger number of KMT2A rearranged patients that are noted here, among whom you see very promising composite remission of 33%. There was, this is the safety data that was presented, I believe, by Gus Issa and then subsequently published in Nature, where you see the QT prolongation that was seen in a decent number of patients. Now, these are any grade, but grade 3 or higher QT prolongation was only in 13% of patients. They did not see as much DS as we saw, but later on, I don't know if the phase 2 data is here or not, that did manifest itself. Unfortunately, differentiation syndrome does occur quite a bit, grade 3 or higher, in patients with KMT2A rearrangements and needs to be monitored for carefully. These are the pivotal phase 2 studies related to revumenib, looking at KMT2A rearrangements in ALL and AML, as well as a focus with 2C on NPM1 mutated AML. This is data that was, I think, presented, if I'm not mistaken, by Ibrahim Aldas at ASH last year, with an overall response rate of 63%, composite remission rate of 23%. There was, just looking at it, some degree of probably count suppression that may have accounted for getting from a composite remission to an overall response rate. That is something I think that was noted by some of the folks that saw this, that perhaps there is a signal there with revumenib. So there is still a lot for us to learn about with these agents, and there are multiple ongoing studies for both revumenib and ziftomenib with single agents that we've talked about, but also in combination with induction, with HMA-VEN, with FLT3 inhibitors, you name it. So a lot more to come. And one other thing I would say is that this specter of differentiation syndrome, which can be lethal and dangerous and scary, probably when you give it concurrently with treatment and try to reduce these patients, the likelihood of something horrible happening with DS in our experience seems to be lower, which really goes to say that perhaps the future of menin inhibition may really well rest in combination. So let's see. Next steps. Dana is counseling on the potential of receiving a menin inhibitor as part of a clinical trial. For this patient, is a menin inhibitor trial the best option? Okay, so why don't we can talk about some of this, I guess, later, just to sort of, let's get to the follow-up polling question. In your opinion, which of the following best reflects current evidence with menin inhibitor therapy in relapsed refractory AML? All right. I think folks answered it. The only thing I would say, this was a tricky question. That last one, I do think it's probably much more promising in combination. What you guys picked is correct, but I also think that these drugs are ultimately going to be most promising in combination over time. In fact, Gus Issa is doing a triplet already with HMA-VEN and menin and revumenib, and that's shown really remarkable data, albeit in a limited number of patients.
Yeah, and there's going to be data at EHA from the Beat AML frontline as well with AZA-VEN and revumenib, which is I can say very, very nice. And I think we're going to see that with most of them. So I think we have just a few minutes. I think we can go a couple of minutes over, but there's a lot of questions here. So maybe we can try to rapid fire do some of these. I can take the first one quickly. Any co-mutation in FLT3 ITD that may compromise the efficacy of FLT3 inhibitors? Yes, in general, I think WT1 is one where we see shorter responses. Some of the RAS/MAP kinase mutations often expanded relapse, caused resistance. So we have seen that, and rarely we've seen on-target F691 gatekeeper mutations. Let me turn this one over to either Eunice or Amir. Will there be a role for menin inhibitors upfront? Can we really expect more improvement in NPM1 AML frontline? I think it's a good question. So frontline, do you think there's a role to add a menin, I guess, let's say to HMA-VEN, and what would you like to see to believe this is better? Eunice, you want to start? Yeah.
So for the 7+3 combos, and I'll have Amir address the low intensive. So the enrollment for the some of the current upfront FLT3 menin inhibitor trials for NPM1 mutant patients require them to not have FLT3, because most of the audience would agree that a FLT3 mutant patient, the standard of care remains FLT3 inhibitors. And many of the ones that are enrolling the NPM1 patients require there to be, as in our first place, some evidence of some adverse risk characteristics. Now that may be for whatever it may be, age. Older patients with NPM1 mutant disease don't do as well. So patients above the age of 60, or patients, as in that first case, that had some sort of co-mutations, DMNT3A, spliceosome mutations, RAS mutations, other signaling mutations that confer what we think a possibly adverse outcome. So I do think that there is a potential for those particular NPM1 patients to have their outcomes improved with the addition of a menin inhibitor, because as we discussed ad nauseum, that those may confer a worse prognosis.
Any other thoughts, Amir?
Yeah, I mean, it's still early. I mean, I think most of the data that we have right now is upfront with induction chemotherapy, which has been, quite interesting and intriguing, and we hope to present that soon. But also combinations with HMA and VEN in the relapse refractory setting. That's an interesting patient population, but I think ultimately what we want to do is move it into the frontline setting, just like what Gus is doing, to see whether we can really have an effect there. Because these drugs are, in my view, highly effective, but almost like, have a flicker where they could be potentially dangerous. So if you're able to ameliorate some of that risk by cytoreducing them, I think you can really have a huge impact in certain patient subsets.
Yeah, I think we'll have to, it's like IDH and NPM1. I think those are a little bit harder to show the difference. I think the KMT2A is going to be very, already with some of Gus and the beta AML data, clear. So this was an interesting one. Real world data with HMA-VEN, what has been the experience and what have you seen? Is it being used as we hoped, or?
You're asking me. Okay. Yeah. So real-world data with HMA and VEN have definitely shown I think, a progressive uptake of the use. So I think we were seeing a lot of single-agent HMA, which is getting much better. I think patients are getting it. I think the real-world data are actually existing. I mean, there are a couple of initiatives that have looked at this very much. I think that we need more, because people would like to know, how do you actually do these cycles, and how many cycles are people getting, and how many days are they getting? But I think it's absolutely increasing. I can help you with a couple of these just to flow through quickly. That just a couple of things caught my eye. Somebody wrote, if an IDH2 is just at the level of detection, would you just do AZA-VEN? And I'm not exactly sure. I think I understand the question, but so yes, when you detect low-level IDH mutations, going ahead with azacitidine and venetoclax is okay, but this came up in the context of something else. I think in Eunice's, when we were talking about repeating mutational testing for a patient at the time of relapse, you absolutely do want to do. However, IDH1 and 2 mutations are often persistently detectable by PCR in patients being treated with HMA-VEN, and that shouldn't actually be a reason necessarily to switch to another therapy if the patient is otherwise doing well and in remission. So I wanted to just squeeze that in there, because I think that it's different to repeat a mutational study at a time of relapse and see if the mutation is still there or if there are new ones, but you don't want to be randomly switching around because of residual detecting of low copy number types of IDH1 and 2.
I almost wonder if whether the question, it may be that, but whether the question is, should you do HMA then even if the IDH2 is that low, I guess, is the question. You could be interpreted. I don't know if the impressive results you would otherwise get with IDH2 you would see in that patient, given sort of the low burden. Both IDH2 and IDH1 I have seen, and it's been published as sort of chip anomalies, so you can see it. But so it's a little bit tricky. Like Gail, I don't think it should preclude you or distract you from not using HMA-VEN. I just don't know if you're going to have the same impressive result as you would in a patient who has like a VAF of 35-40% IDH2. It may just be a very different type of alteration that may not be involved with the patient's AML.
Yeah, I thought that the question was maybe do you add a third drug triplet? Like, do you just do AZA-VEN if your IDH2 is like 2% versus considering the triple therapy?
Yeah.
Or if an IDH1 setting, I think it's a very good question. This comes up, you have like a 3% IDH1. Do you do AZA-IVO? Do you do AZA-VEN? And I think sometimes I may consider maybe doing ACME-VEN because if they have other mutations and they have a really small allele of the one, the same will come up with NPM1 and FLT3 when you have menin inhibitors and FLT3 inhibitors in combo. So we don't really know, but these are going to be good questions.
And I think in some of the initial studies of the IDH1 inhibitors, the effect of the IDH inhibitors were not dependent on the degree of the VAF. So if you had a high VAF or you had a low VAF, you still responded to treatment with IVO and enasidenib in the relapse setting. So
I agree. I would be careful with that. Okay, I'm going to take Chair's prerogative to shut the things down with a couple of very brief comments that I think everybody will agree with. Number one, for TP53 mutated AML, I think we can all agree that we really, really, really need and want something different. But what I wouldn't do, any role for intensive chemotherapy plus BO or venetoclax in that setting, I'm not sure that hammering TP53 patients with further intensifications of therapy would be good, so don't do that. Second point that has come up a couple of times in the questions, that whatever your classification was at the beginning of AML, it's not good when you relapse. So there's no such thing as a favorable relapse. Any relapse is dangerous in AML and needs treatment, but whatever you were classified originally goes away, and I think that's a super important point. And the last comment of the day is that MRD is what we hope will lead the way, and what you're going to start seeing, and maybe menin will come here too, we're not there yet, but for the molecularly classified AML patients, it's molecular MRD. So flow cytometry is going to be outclassed. It has already been for the patients with NPM1 and for FLT3. There are very clear data for that, and it's actually going to come out in the guidelines. So I think with MRD leading the way, hopefully to better news for AML, we'd like to thank everyone so much for participating, for staying, and for all the excellent questions. And we'll hang out up here for a few minutes in case there are more. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/YGR860. This activity is supported through independent educational grants from AbbVie, Astellas, Bristol Myers Squibb, Daiichi Sankyo Incorporated, Kura Oncology Incorporated, and Rigel Pharmaceuticals Incorporated.